Now, today we are going to talk about chest leads, right? Which are also called precordial ECG leads, right? Precordial ECG leads. Now, what is the special thing about the chest leads? Chest leads basically determine the electrical activity of the heart transmitted along the horizontal plane. Transmitted along the horizontal plane. Here I must make it clear that limb leads also determine the electrical activity of the heart, but in the frontal plane. Let me make this plane business clear to you, right? Here is your friend, right? Now this is your frontal plane of the body, which is displayed in this diagram. This is right, left and up and down. Okay, you have beautiful legs and you have arms too. Now, this is frontal plane. When electrical activity of the heart is initiated in the chest, it is transmitted along the frontal plane as well as transmitted along the horizontal plane. Horizontal plane means anteroposteriorly, right? Limb leads are designed to determine the electrical activity of the heart, which is transmitted along the frontal plane, and chest leads are designed to determine the electrical activity of the heart, which is transmitted onto horizontal plane. Let me show in this diagram horizontal plane. Now this is the horizontal plane of the body. Right? Anteroposteriorly, right? Anteroposterior dimension. Or we also call it not only horizontal plane, we also call it transverse plane. Is that right? This vertical plane is basically frontal plane, right? Now, let me put the heart over here. Now this is the section of the heart I put over here, and this section of the heart is showing along the frontal, what is it, transverse plane. Is that right? Now, when electrical activity is initiated by the heart, it may go up, it may go down, it may go right or it may go left. This right-left movement of electrical activity and up and down movement is frontal plane, but this may move anteriorly or posteriorly. This movement is along horizontal plane. Now, chest leads are designed in such a way that we put the exploring electrode on the chest wall. We put the exploring electrode on the chest wall, which determines the electrical potential at the site of the electrode, electrical potential produced by the electrical activity of the heart at the site of, at the placement of the exploring electrode in reference to the indifferent electrode. It means now I need to make clear your concepts between the exploring electrode and indifferent electrode. Is that right? Let's put a galvanometer here, our ECG machine. Right? This is our recorder, ECG recorder. Here it is positive electrode, right, positive terminal, and here it is negative terminal. Now, when we are constructing chest lead, number one, we should have exploring electrode. Now, exploring electrode is connected to the positive terminal of the machine, and this can be applied to the, yes, what is this? Surface of the chest wall, right? This is applied to the surface of the chest wall. This is also called, yes, exploring electrode or positive electrode. Now what we see, we are constructing a chest lead. We have applied the positive electrode on the surface of the chest. Is that right? In this case, whatever electrical activity will be transmitted along the horizontal plane, this positive electrode, or more truly speaking, exploring electrode, will be able to detect that electrical activity. Now, this exploring electrode will detect the electrical activity in relation to the indifferent electrode, in relation to the near zero electrode. You must remember that chest leads are unipolar leads. Don't tell chest leads are unipolar limb lead. Unipolar limb lead is a different story. But chest leads are also unipolar leads. It means they must have one exploring electrode and one indifferent electrode, which can be also called near zero electrode or null electrode or reference electrode, right? Now, how do we construct indifferent electrode for the chest lead? Answer is that negative terminal, this negative terminal that is connected at, yes, one negative is applied, it is connected through a common terminal. Okay, I must make it clear. Negative terminal has a common wire and this wire is connected, here it is connected to the negative, or make it more upward. Let's make it like this. This is negative terminal. And this is another connection of the negative terminal, right? It is on the right, yes, arm. Here it is on the left arm, and one part of that is connected to the left leg. Now you see that basically negative terminal is a common terminal, for the connected to the, as a common terminal connected to the right arm, left arm and left leg, and it is connected through high resistance so that there should be minimal current flow, right? If you remember previous lecture, let's come over here. If you remember previous lecture, we talked about Wilson central terminal. What was Wilson's? When we construct a unipolar lead, whenever we are going to make a unipolar lead, I'm not talking about chest lead now, generally speaking, unipolar lead, right? In case of unipolar lead, positive terminal is attached with the exploring electrode. What is this? Exploring electrode, and negative terminal is attached, is a common terminal. Here it is attached with left arm, then it can be attached with the right arm, and it can also be attached with the left leg. Is that right? And everywhere there is high resistance. Now this will make, when it is applied on the right arm and left arm and the left leg, if you see, it makes a sort of triangle, right? And if your mathematics is too good, then you can understand that if potential at the corner of equilateral triangle is same. For example, heart is here and heart is generating the electrical activity. Now this electrical activity is transmitted along these parts. So this electrical activity which is produced by heart at any moment, it will be detected by the right arm as well as left arm as well as left leg. So all the potentials, right, they are added together. They are added together, and it means what is added together? Potential from the right arm plus potential from the left arm plus potential from the left leg, right? And all of them divided by 3. All of them, because we average them. We average them. And when we average them, the central potential, the potential at the center of the triangle is almost 0. Because these 3, what is this? Electrodes pick up the same potential and make an average through the common terminal. And it is almost near 0. Is that right? By mathematical calculations, when a same potential is present, either positive or negative, it doesn't matter, but same potential is present at the angles of what? Equilateral triangle, then potential at the center of the triangle is 0, right? And because it is not really perfect equilateral triangle, and heart is really not present in the perfectly central position, that is why little bit current flow may be there. To reduce that, we add what are these resistances? 5000 ohm resistance. Now, this negative terminal, right, which is averaging the potential of these 3 points, this is called Wilson central terminal. What is this called? Wilson central terminal. So we can say that Wilson central terminal potential detected by the Wilson central terminal. Now this is the Wilson central terminal. This, we have converted the negative terminal of this machine into Wilson central terminal. So Wilson central terminal determines the potential at 3 points of the apices of the equilateral triangle, right? Or it averages these, which is usually almost 0. That is why when you are putting this kind of arrangement and connection through the negative terminal, we can say we have placed a virtual terminal at the center of the triangle, which is having what? Yes, what? Almost 0 potential. You are getting it? Because when you are connecting these 3 together, when you are connecting these 3 electrodes potential together through one negative terminal, then the average potential picked up from all these 3 places is like 0 at the center. So we can say, for practical purposes, even though we have applied the electrode at right arm, and left leg, but as center is 0, right, center is considered virtual terminal. Is that clear? Now we come back. So what is this? We have made this Wilson central terminal. What is it? This is Wilson central terminal. And Wilson central terminal will result into a virtual electrode. You can say virtual electrode at the center of the heart. Virtual electrode at the center of the triangle, or we can say it will produce a virtual electrode in the center of the heart. Is that right? Am I clear? Now, basically, in chest leads are unipolar leads. Chest leads are unipolar leads. They are having one exploring electrode and they are also having an indifferent electrode, right? And they are determining what is the function of the chest leads. They are determining the electrical activity of the heart transmitted along the horizontal plane by applying the exploring electrode on the surface of the chest and making the indifferent electrode in the center of the heart by formation of Wilson central terminal applied on the negative pole of the machine. Is that clear? Now let's define it once forever. What are chest leads? Number one, chest leads are unipolar leads. And you know unipolar leads have two poles. They are not perfectly unipolar. Unipolar leads also have two poles. One positive pole, which is exploring electrode, one negative pole, which is also called indifferent pole or indifferent electrode. So what are chest leads? They are unipolar leads, right, having a positive exploring electrode and an indifferent electrode constructed by the Wilson central terminal. And this positive electrode or exploring electrode is applied on the surface of the chest, and it determines the electrical activity of the heart transmitted onto horizontal plane. Is that clear? Now, or we can say that, let's suppose you have applied the positive electrode here, indifferent electrode is here, so these are the axes of the lead. These are the axes of the lead. But if you put this, remove from here and put it here, let's suppose we remove it from here and we apply this over here. Now if we keep this at the same point, when we are doing recording by the chest lead, we don't produce any alteration in the central Wilson terminal, which is here. So it means we do not change the indifferent electrode. When we are recording different chest leads, right? What we are doing, we are placing this exploring electrode at different positions. For example, if it is here, axes of the leads are these, right? It means the electrical activity of the heart along the horizontal plane is compared through this axis of the lead. But if we put positive electrode here, we move it here, right? Then axis of the lead will change. And if you put this positive electrode, remove from here out and remove from here, and you only apply over here. Now axis of the lead will become like this, because negative pole will remain the same indifferent. Positive pole or exploring electrode, you can change the position to look at the electrical activity of the heart from different angles. You can look at the electrical activity of the heart while it is being transmitted along horizontal plane. Am I clear? So this is a classical chest lead. What is a classical chest lead? It's a unipolar lead having a positive electrode, exploring electrode, and an indifferent electrode. Indifferent central electrode is present in the virtual electrode or in the center of the heart, and positive electrode you place at different positions of the chest to determine the electrical activity of the heart transmitted along the horizontal plane. Any question up to this? It's done. After this, now I will tell you exactly what is the potential determined by voltage, potential determined by a chest lead. Voltage which is determined by any given chest lead, let's suppose this is the chest lead, is equal to potential by the exploring electrode. This is, now listen, there is a potential determined by exploring electrode. There is near zero potential determined by virtual electrode. You are understanding it? And what this machine is recording, which potential this machine is recording, I'm going to ask you. This machine is recording the potential of exploring electrode, or this machine is recording potential of the virtual electrode. Yes.
Potential of exploring electrode.
So you say it is recording potential of the exploring electrode. Let me make you more accurate. You are accurate, but let me make you more accurate. Actually, this chest lead is recording graphically recording the potential difference between the potential determined by the exploring electrode and the virtual electrode. All the ECG leads basically don't determine the absolute potential from a site. They determine the potential difference between the 2 points. Here all the chest leads determine the potential difference between the exploring electrode and the virtual electrode. As we know, virtual electrode is almost near zero. So for practical purposes, the lead is recording the potential which is actually mainly determined by the exploring electrode. You are understanding? Any question up to this? There is no question. Now, once we have determined this, so it was here that voltage determined by a chest lead I. Voltage or potential determined by a chest lead I, because suppose this is one chest lead, between this and this, other chest lead is here, another chest lead is here. All of them are determining the potential difference from this surface point 1, 2 or 3 as compared to the reference electrode or virtual electrode. So voltage which is determined by the unipolar chest lead is equal to potential determined by exploring electrode minus the potential determined by the Wilson central terminal, which is itself equal to right arm plus left arm plus left leg potential divided by 3. Did you get it? What did we learn? That chest leads determine any potential from the surface of the chest, is that right, between the exploring electrode potential and the virtual electrode potential. Is that right? Difference between them. Any question? And now we come to how do you place chest lead? I want to, before really I move forward, I want to make one more comment. During a cardiac cycle, even though electrical activity produced by the heart varies during a cardiac cycle, at different phases of the cardiac cycle, electrical activity produced by the heart varies. Sometimes it is atrial depolarization, sometimes it is septal ventricular depolarization, then there is major ventricular depolarization, right? So, during the cardiac cycle, while electrical activity produced by the heart varies from time to time, but virtual electrode remain almost zero or near zero with a constant potential, because when electrical potential of suppose atrial depolarization is produced, that is transmitted in the same way on these 3 points. Ventricular depolarization is more powerful, but it is transmitted on the same way. So it is almost always kept zero. So we say not only it is near zero, it is constant. The potential of the virtual electrode is not only near zero, it is also constant throughout the cardiac cycle, or it does not fluctuate significantly. But exploring electrode do record the electrical activity of the heart produced during the different phases of cardiac cycle in a different way. Do you get it? When atrial depolarization is being produced, this electrode will record different type of wave. When ventricular depolarization is being produced, this electrode will sense different potentials and record in different way, which we will see later. Am I clear? Any question? Okay, done. Now we come to the placement of the standard placement. There are 6 chest leads which are standard chest leads, unipolar chest leads, and then there are additional leads. Today we will not talk about additional leads. I will discuss mainly the concepts related with the 6. This is 6 chest leads, right? How do you place, where do you place the exploring electrode? Remember, for all those 6 leads of the chest, Wilson central terminal remain the same for all of them. Only you change the position of the exploring electrode. You only change the position of the exploring electrode. Now let's see in different chest leads what are the specific placements, positions on the chest where you apply the exploring electrode. Let's talk a little bit about the bony landmark on the chest. Bony landmark. You must be knowing that there is something called, yes, here the upper bone, this is manubrium, and in the center this is body of sternum, right? Now this is manubrium, and here it is, what is this? Sternum. Now, and there is a bone here. Okay, I will make it more simple. What is this bone here? Clavicle. Good. It's a very simple diagram. These 2 bones are going clavicle, right clavicle and of course left clavicle. These are clavicle. This is manubrium sterni. This is manubrium sterni, and here's the body of the manubrium. Now we talk about the ribs, right? First rib is of course very much under it, right? It is here. This is your first rib. I'm going to make a diagram to show you rib cage. This is, here it is, which rib? Second rib, right? Yes. Second rib, and of course there is no fun in telling under that which rib should be there? Third rib. And here I'm going to tell you actually how these chest leads, exploring electrodes are placed at what points. And what is this rib? Fourth rib, very good. And here it is? Fifth rib. Okay? Here it is? Fifth rib. And then so and so. Fourth, I will not go into more detail. Now, where to put your electrode? First, actually there are 6 chest leads. First of all, talk about first chest lead, which is called V1. Right? Now V1, to construct V1 chest lead, right? Wilson central terminal remains the same. But where to apply the positive electrode or exploring electrode? That is in the 4th intercostal space, just right of the sternum. Now how do you determine where is the 4th intercostal space? For that purpose, you must be able to identify the bony landmark on the chest. What do you do? This is, what is this? Sternal notch. From the sternal notch, the little depression here, you move your finger downward. About 1.5 inch down, you find a horizontal, what is this? Ridge. This is called manubriosternal angle. It is also called angle of Louis. Angle of Louis. Angle of. Now, what you do, how you identify the intercostal spaces? One of the standard method is, you in the patient's sternal notch, you put your finger. While feeling the bone, you move your finger downward. About 1.5 inch below the sternal notch, you will find a horizontal ridge. This transverse or horizontal ridge is manubriosternal angle or angle of Lewis. Now, just outer and inferior to this angle, there is second intercostal space. Which space? second intercostal space, infrolateral. Of course, this is right. Second intercostal space, this is left. Second intercostal space is between the second rib and the third rib. And then you move two spaces more down. First you identify this point, angle of Loewe, infralateral to this there is second intercostal space. Then you move two spaces down. Of course, here will be third, and then here should be fourth. So these are your fourth intercostal spaces you determine on the right side and the left side. When we are going to record the voltage for V1, ECG pattern for V1, you put positive electrode here. Fourth intercostal space, this is the V1. Fourth intercostal space, just right of the sternum. You put your exploring electrode here and record the ECG pattern. Then you can move this to the other side, and you can move this exploring electrode to fourth intercostal space on the left side, not on the right side, just left side of, what is this? Sternum. And then it is V2. Now listen, when exploring electrode is here, it is determining the potential difference between this specific site and the virtual electrode in the center of the heart. You're getting it? But when you move the exploring electrode to a new position, you make a new chest lead, while keeping the indifferent electrode same, but you have altered or changed the position of exploring electrode. Is that clear? Now this exploring electrode has moved to this position, and this is what? Yes, V2 position, right? Or this is the specific point where you place the positive electrode to record the V2 chest lead. Then, after that, you have to record the chest lead V3. That will record the electrical activity of the heart transmitted along the horizontal plane from a little different angle. Actually, lead 3 is applied to construct chest lead V3. You place the exploring electrode midway between the place of V2 and V4. So it means we must know placement for the V4 first. V4 is applied in the fifth intercostal space. What is this? This was fourth. This is fifth. Fifth intercostal space in the mid-clavicular line. This is the mid of the clavicle. Mid-clavicular line. So at this point, you will put positive electrode and record V4. You will record V4. And to record the V3, actually you will place the electrode midway between the position of V3 and V4. So here should be the position for V3. Is that right? So when electrical activity is determined by fourth intercostal space, just right of sternum, the electrical activity which is determined, that is V1. Just left of the sternum on fourth intercostal space, it is V2. Between the V2 and V4, midway you put the exploring electrode, you have constructed V3. And if in mid-clavicular line, in the fifth intercostal space, you have put the positive electrode, it is V4. Then you move it horizontally, laterally and backward. Laterally. If you move horizontally, laterally at the same level of what? V4. Right? In the same level, same horizontal level. Right? And you come to interior axillary line. What is this line? There is axilla here. Right? In my case, this is interior axillary line. And here it is mid axillary line. And behind there is posterior axillary line. All of you must be knowing that. So interior axillary line, what you do at the horizontal plane, I will put it a horizontal plane, right, at the level of the V4, which is fifth intercostal space, and what is this? Anterior axillary line. So this will be the position of V5. This should be the position of V5. And then you move more laterally and you place the electrode in mid axillary line, in mid axillary line at the same horizontal plane as V4 and 5, and now you are placing it here, and this is V6, right? So these are placements of specific positions on the chest for placement of exploring electrode for 6 standard chest leads. Right? There are some additional chest leads also, which I will not talk now, but they can be applied more to the right side or they can be applied more posteriorly. We will not discuss those now. So these are 6 standard chest leads and placement of specific sites where you place the exploring electrode. Where you place the exploring electrode, right? Now, here I want to highlight something very important. Please use the bony landmark. Use the bony landmark to determine the specific site where you will put it. Don't use the nipple. Nipples are very deceptive. Nipple position varies from person to person, even in males, and about females, their nipples are very, they change. In young females, they are little upward, right? As number 1. In females, nipple position depends a lot on the size of the breast and shape of the breast and parity of the woman, how many children she has, and even age of the woman. So, what I'm saying, that in females, nipple position varies widely. Not only female to female, but within the same female at different stages of life and with different parity. So don't use nipples to determine the intercostal spaces. But just I will mention, in a young female, usually nipples are at the level of 4th intercostal space. Right? But preferably, don't use, forget about what I told you about young females. It's better not to talk about this breast issue and nipple issue, because these are chest leads. These are not breast leads. These are chest leads. Remember that. These are not breast leads. Why I am so much stressing on this? Number 1, nipple position problem. Number 2, sometimes women come with a large breast. And very young doctor get confused where to put the leads. What you will do? You will remember these are chest leads, not breast leads. Don't put electrode over the breast, because there are multiple problems with that. You are supposed to put the electrode underneath the breast. Especially, of course, this will be the left breast. For V1 and V2, there is no problem. Breasts are on the side. But for V3, 4, 5 and 6, you will always, I must say almost always, you must put the exploring electrode where? Underneath the breast. Don't put on the breast. Why? Number 1, if you put it on the breast, voltages which are picked up may be reduced. Attenuated voltages may be reduced or attenuated. Secondly, maybe you are recording from a higher intercostal space than you are supposed to. Thirdly, what do you think? What could be a problem with the breast if you put your electrodes on the breast? Motion artifact. Of course, all of you should know that breasts are more mobile than your ribs. Am I right or wrong? You know that. Good. So, the point which I want to stamp on your brain is, these are chest leads, not breast leads. So don't get confused. When a lady with a large breast comes for ECG, you are supposed to put chest electrode V3, 4, 5, 6 underneath the breast, not onto the breast. Second point, which is also I will repeat, that please use the bony landmark to determine the intercostal spaces. Don't use the nipple position, which is very deceptive. Clear? Okay. Now this was about what we have discussed up to now. We have talked about what are chest leads. Chest leads are unipolar ECG leads having an exploring electrode and an indifferent electrode. Exploring electrode is applied on the surface of the chest, and to determine the electrical activity of the heart, which is transmitted along the horizontal plane. This is chest lead. How do you construct a chest lead? Very simple. Positive electrode is applied on the surface of the chest at different positions depending upon which chest lead you are recording, and negative terminal is connected through 3 wires to the right arm, left arm and the left leg through the resistances to make a common central terminal, which results in the production of indifferent virtual electrode in the center of the heart. And exploring electrode is determine the potential difference between the virtual electrode and the electric potential determined at the site where the exploring electrode is applied. Is that right? Anything? Then placement. We have already discussed. V1 position is for the, these are 6 standard chest lead. V1 on 4th intercostal space on the right side. V2 4th intercostal space on the left side of the sternum. Right? V3 between the, midway between the V2 and V4 position. Very good. And V4 is in the 5th intercostal space in mid-clavicular line. And then, listen, in the same horizontal plane, more laterally, V5 is placed interior axillary line, and this is applied on the mid axillary line, and sometimes you put V7, that is posterior axillary line, but that is additional lead. Any question up to this? And always take care, you are using bony landmark for positioning of the chest electrode. Is it not nipples for the positioning? And number 2, in females with large breasts, please put the, even with the small breast or large breast, whatever breast, you have to put the electrode V3, V4, 5, 6 underneath the breast. Any question up to this? Okay. After this, now we come to another concept, and that concept is about the orientation and classification of the chest leads. This is very important because different authors and books mention classify chest leads in different way. So I will try to reduce this confusion at least. So be attentive and careful, right? That how do we classify these 6 standard chest leads? How they are classified? Let me put a heart over here. Yes, this is of course left ventricle and this is right ventricle, right? This is interventricular septum, and I've made a section of the heart which is basically, yes, along the transverse plane or horizontal plane, right? Here is the wall of the interventricular septum. Here is wall of the left ventricle. Am I clear? Now, if we place the chest leads, how they will be placed? I will put it with the black color. Here is V1 position. Here is V2 position. Here it is V3 position. Yes, good. Here it will be V4 position. Yes, very good. And here it will be V5, and here it will be V6. Okay, let me place it again. Right? Here we should apply the V6. It is on the left side. This is V6. Here it is V5. And okay, let me draw it more. Yes, 5. And this is here it is V4. Yes. V3 and V2. Right. Now, this is the what I'm showing anatomically a section of the heart, right, along transverse plane and relative position of the, what is this? Chest leads, right? Now, if you see the orientation of the chest leads, if you look at the orientation of the chest lead, V1 and V2, these two are oriented to the right side of the heart. I'm talking about anatomically. Anatomically, V1 and V2 are oriented over the right side of the heart. V5 and V6 are oriented over the left side of the heart. Right? V1 and V2 are oriented over the right side of the heart. V5 and V6 are oriented over the left side of the heart. And if you look at V3 and V4, they are oriented over the septum, interventricular septum. They are oriented over the septum. This is relationship. This is a relationship of, yes, chest lead exploring electrode site and underlying heart. So we can say anatomically these are oriented from the right, over the right side of the heart. These are 5 and 6 oriented over the left side of the heart, and V3 and V4 are oriented over the septum. Clear? No confusion. But I want to make one more thing. This is only anatomically, but actually leads are determine the electrical activity of the heart. Leads are determining primarily the function of them is to determine the electrical activity of the heart. Now, during ventricular depolarization, I will just make two vectors of the ventricular depolarization. During ventricular depolarization, ventricular septum is depolarized from, yes, from left to the right. In my early lecture, if you don't know this, refer to my earliest lecture on ECG, basics of ECG, that interventricular septum undergoes depolarization from left to right. And after that, once the septum is almost depolarized, major part of ventricles, both ventricles undergo depolarization. Both part of ventricles undergo depolarization. Right ventricle undergoes depolarization rightward, and left ventricle undergoes depolarization left side in the horizontal plane. But because left ventricle is thicker, the common vector of major ventricular depolarization is oriented towards the left. Now what is this vector? Left and little backward. What is this vector? Vector of major ventricular depolarization. And vector of major ventricular depolarization is in the horizontal plane. It is directed leftward and slightly backward. Leftward and little backward. Listen, actually, major ventricular depolarization in 3 dimensions, major ventricular depolarization vector is directed leftward, number 1, not only downward, it is leftward, downward and slightly posteriorly. Even though left ventricular depolarization moves downward, but that component of the vector is recorded by the limb leads, not by the chest leads. Chest leads only record the component of the vector which is mainly moving, major ventricular vector moving leftward, primarily leftward. Is that right? So it means this is septal depolarization, this is major ventricular depolarization. So I'm showing here two ventricular electrical activity vectors. Now look here, V1 and V2, right? Even though they're placed over the right side of the heart, but they are more sensitive to the septal electrical activity. They are more sensitive to the septal electrical activity of the heart. They are more sensitive, V1 and V, to the septal depolarization. That is why functionally they are called septal leads. Functionally V1 and V2 are called septal leads. V1 and V2 functionally are called septal chest leads. Septal leads. Am I clear? And V5 and V6 are most sensitive to the major ventricular depolarization, which is moving leftward. Because this is leftward, so functionally they are also called left leads. So it means V5 and V6 are anatomically oriented also on the left, from the left side, and they are functionally also determined that they are most sensitive to the major ventricular depolarization vector, which is moving left. Why we need to make this functional classification? Let me tell you. This is because when we are determining different type of myocardial infarction signs in the chest leads. When there is myocardial infarction, I will call it MI. When there are interior MIs, they can be, of course, diagnosed by certain signs, which I will discuss later in the recording of chest leads, interior MI. Now, if MI is only in the septal area, MI is only in the septal area, then septal electrical activity is disturbed, and it will be best determined by V1 and V2. So for MI analysis or functional purposes, we will call this V1 and V2 septal leads, even though they are oriented over the right side of the heart. Is it clear? Then, if there is myocardial infarction purely on the left side, then this will be mainly showing its changes in V5 and V6. And if there is strictly an interior MI, if there is strictly an interior MI, small interior myocardial infarction, that will be showing changes of infarction in V lead, V3 and V4. Is that clear? I have to put it little more laterally. 4 should come here and 3 should come here. Okay. Now here, previously we mentioned that anatomically V3 and V4 are oriented over the septum, but functionally they are most sensitive to very interior myocardial infarction or ischemic changes. Is that clear? No confusion? And when there is lateral myocardial infarction, which leads will record? Left leads, left chest leads. Left chest leads the V5 and V6. And of course left limb leads also, which you already know. Left limb leads are lead 1, bipolar limb lead 1 and AVL. Is that right? Now I will mention here, if myocardial infarction is in the septum, what are the leads recording? V1, V2. If it is strictly interior MI, which leads are recording the changes? V3 and V4. If there is left lateral wall, left ventricular lateral wall MI, best ECG infarction changes will be seen in which lead? V5, V6 of the chest. But actually sometimes infarction is more extensive. If infarction is only this area, this is septal infarction, the septal lead. It is strictly interior infarction, and this is which infarction? Lateral infarction. But sometimes infarction is in the septum as well as in the interior area. If it is so, then changes will be seen in V1, V2, V3 and V4. If all these changes are seen V1, V2, V3 and V4, the infarction will be called septal as well as anterior. We call it anteroseptal, or we call these leads V1 to V4 as collectively V1, 2, 3, 4 are called anteroseptal leads. Anteroseptal lead. And if infarction is in interior part and extend laterally too, then this will be, yes, extending from here and going to the lateral side too, then this infarction will be showing changes in V3, V4, V5 and V6. And V3, 4, 5 and 6, they are called anterolateral leads. Or if infarction is shown in these leads, then we will say there is anterolateral infarction. Now, let me repeat it here. You guys will now tell me what I am drawing, okay? I will make it a simple diagram. V1, yes, V2, V3, I am repeating it, V4, here it is, V5 and V6. Clear? Now, first of all, anatomical orientation. V1 and V2 are oriented over right side of the heart. V3 and V4 are oriented over septum of the heart. V5 and 6 are oriented over left side of the heart, left lateral. Clear? Then, electrically, V1 and V2, if you are looking, let's suppose, about ischemia or infarction, or you are just looking at major changes in electrical activity of septal depolarization and major ventricular depolarization, then V1 and V2 record septal activity, septal electrical activity, they record interior electrical activity, and they record lateral. Now, if there is changes in V1 and changes extend up to V4, what is this? Anteroseptal. And if changes are from V3 and extend through V3, V4 and also changes are shown V5 and 6, what is this? Anterolateral. Some people call it anteroapical also. Now another thing. And if changes are in V2, V3, V4 and V5, this is not very lateral, this is not very septal. So what is this? A large interior MI. So what I really wanted to put in your mind is that there are two ways to classify chest leads. Number one, how they are oriented over the chest, over the heart, then there are right leads, interior leads and left leads. And how they pick up the electrical activity from various parts of the ventricles. Then V1 or various part of the V1 and V2 are mainly septal, V3 and 4 are still interior, V5 and 6 are lateral. And if changes are from V1 to V4, anteroseptal. These are anteroseptal leads. From V3 to V6 are classified as anterolateral, anteroapical leads. And V2 to V5 are considered classified as main interior leads. Is that clear? Any question up to this? Now the last thing, that how these leads are oriented, angle of orientation in reference to each other. This is the last point, and I will make it here. This is the chest. Here is, let's suppose, sternum. Okay? A heart is really not in the very center of it. So I will put it here. Now, actually, what is this lead? This is V2. Here it is V1. And here is V3, V4, V5 and V6. Now, of course, these are the positive poles of these leads. And if you cross through it, then it will be negative poles. 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. Okay. Now what I want to say, how many degrees there is difference with each other? The positioning. It is almost 30 degrees. They are oriented, the placement, the angle of one axis of one lead in reference to the angle of axis of other leads, the difference is about 30 30 degree. If you keep it here, this is 0. If you go backward, P6 is minus 30. And if you move it to V4, it will become plus 30. It will become plus 60. Here will be plus 90, and here it will be plus 120. Right? So we can say that these chest leads axes are oriented relative to each other along the horizontal plane almost or approximately 30 degree. Why I said approximately? Because these degrees depend on orientation of the heart within the chest. They also depend on the, you can say, anatomical aspects of the chest, which varies from person to person. Right? Do you have any question up to now? There's no question? Anyone? So this finishes today's lecture. I will very rapidly review this lecture, very rapidly. Number one, what are chest leads? Chest leads are unipolar leads. These are unipolar leads consisting of one exploring electrode and one virtual indifferent electrode in the heart, produced by the Wilson central terminal. Done? They are supposed to determine the electrical activity of the heart transmitted onto horizontal plane. Clear? Chest leads are, say there are 6 standard chest leads, right? In every standard chest lead, exploring electrode position is altered, changed. In V1, force intercostal space on right side. V2, force intercostal space on left side of sternum. V3, midway between V2 and 4. V4 in the fifth intercostal space. Fifth intercostal space in mid clavicular line. V5 and 6 on the same horizontal plane with V4, but V5 in the interior axillary line and V6 in the mid axillary line. Then, how do you classify chest leads? Anatomically oriented, V1 and V2 are oriented over right side of the heart. V3 and V4 are oriented over the septum. V5 and 6 are oriented on the left lateral side of the heart. Functionally, which electrical activity they are picking up, and for MI diagnosis, which leads are more important for a specific type of interior MI. Listen. V1 and V2 look at the septal electrical activity. So they are septal leads. V3 and V4 are here interior. Functionally they are interior leads. V5 and 6 are functionally lateral leads. Clear? Then if MI is strictly in, MI changes are only in V1 and V2, septal MI. If MI changes are strictly in V3 and V4, strictly interior MI. If MI changes are only seen in V5, V6, right? Lateral. Of course, with that they may be seen in bipolar limb lead 1 and AVR. They are also left-sided lead. Then, if MI changes are extending from V1 to V4, anteroseptal. If they are extending from V3 to V6, anterolateral, anteroapical. If they are extending from V2 to V5, major interior, big interior MI. Is that clear? Now, and if unfortunately, some very unfortunate person has all over changes, some massive interior anterolateral MI with even showing the septal changes, it's had a very bad prognosis, right? And then orientation of these leads. These are oriented with difference of 30 degrees with each other in the horizontal plane. Now, the really most important concepts about the chest leads will be discussed in the next lecture. In the next lecture, I will discuss that from V1 to V6, in a normal person, in a normal heart with normal electrical activity, how QRS complex morphology changes. How the QRS complex morphology changes. And I will mention, rather I should not use the word morphology, keep it simple. I will not say stupid, just keep it simple. Next lecture we will talk about specifically that from V1 to V6, how the ventricular depolarization is recorded with different QRS complexes. And I will also discuss in next lecture what is the concept of R wave progression from V1 to V6. What is the concept of normal R wave progression, what is early R wave progression, what is delayed R wave progression, what is the transition zone related with QRS complex. These concepts we will discuss in the next lecture. So see you soon.